Dr. Lee Silverstein, and I'd like to thank you for taking your time to listen to this lecture. This lecture is part of our new book, Principles of Soft Tissue Surgery, a complete guide, step-by-step procedural guide that I was very honored that both Drs. Salama and Garber wrote the foreword to. I'd like to talk about keys to aesthetic implant placement in a diagrammatic fashion. You know, maturity teaches us the necessity of patience, and we all know it's difficult to achieve. Right? We all want to do the New York Minute and hurry up and wait, but you know, we have to remember that a man with an arm for a hammer views the entire world as a nail. It is very easy to say, oh, someone lost a tooth and let's stick it in. The problem is you have to remember Dale Carnegie's Dress of Success. You know, Yogi Berra has a saying, if you don't know where you're going, chances are you won't get there. It is very important that we set up the case for success. Right? The last thing you do is screw somebody. In other words, place a dental implant. Because the dental implant, once it's in, it's Murphy's Law. The ones that integrate are usually the ones that you place and you go, oh, I wish I had done this. So we have to make sure that we set this up. The last thing we want to do is act like the Three Stooges and basically put ourselves in a head press. We don't want to sit there and couple the hands of our prosthetic dentist. Remember, implant dentistry is a prosthetic discipline with a surgical component. Right? Prosthetic discipline, surgical components. People just care that they're teeth. That's it. Now, how you go ahead and give them teeth, that's a different story. But the bottom line is they want something that looks like a tooth and acts like a tooth and feels like a tooth. Whether or not we're placing a dental implant or we're going ahead and doing a tooth-borne restoration, it does matter how much of the tooth is showing. It does matter whether or not we remember the golden proportion and the length to width ratio. These golden rules will help us sit there and figure out whether or not we need to modify the existing environment prior to doing restorations, whether we're doing restorations on natural teeth or we're doing restorations on dental implants. Everything has to be set up for success, and basically crown lengthening becomes our mode to go ahead and set up this success. People don't care whether or not they have a tooth that's supported by a post and core and gold coping or a dental implant with a prosthetic abutment. They care about the tooth. They just want something that looks like a tooth and feels like a tooth. And that means that we don't want to have a gum line that's at one level for one tooth and 4 millimeters higher for the next tooth. Things have to be right. The matting of the picture has to look like it belongs with the picture. Okay? So there's two rules we have to remember when we're talking about doing aesthetic implant placement. One is the golden proportion. Remember the old saying, if it looks like a duck, quacks like a duck, and waddles like a duck, chances are it's a duck. If we are going to go ahead and replace a central incisor, we're not going to use the same size fixture that we would use to replace a lateral incisor. If we're going to go ahead and replace a molar, we're not going to use the same size fixture that I would to replace the molar as I would to replace a lateral incisor or a lower central incisor. So think the golden proportion. Everything has an effect on the teeth adjacent to it. Okay? Second thing we have to remember is that you don't have people that normally are 6 feet and 200 something pounds and have teeth that are only 4 millimeters in height. We have a length to width ratio. It's about a 75 to 80% length to width ratio. The normal length of a tooth is 11 to 12 millimeters in a guy. It's 10 to 11 millimeters in a female. That translates into usually about 9 millimeters in width for a man, 8 millimeters in width for a central incisor for a woman. Very, very important. There has been a lot of literature published showing that, oh, we can do an immediate dental implant. Take out a tooth and stick in a dental implant. And yes, that can be done, and yes, that will integrate. But if you start out with chiclet teeth and you start out with passive eruption, you're going to end up with chiclet teeth and you end up with passive eruption. There have been articles published that said that in order to have aesthetic implant placement, you need to have 3 millimeters on the direct facial from the crest of the bone to the gingival margin. You need to have 4 millimeters interdentally from the crest of bone to the tip of the papilla. And those guidelines are correct provided the case was set up properly. In other words, the bone itself is where it's supposed to be, as described in the early 60s by Orban and Wentz. Bone is supposed to be in a parabolic fashion about 1.8 to 2 millimeters apical to existing cemental enamel junction in a nice scallop fashion. If bone is located at the cemental enamel junction, or bone is located coronal to the cemental enamel junction, then using the 3 millimeter guideline and 4 millimeter guideline, 3 millimeters from the crest of bone on the facial to the gingival margin and 4 millimeters from the crest of bone interdentally to the tip of the papilla, is irrelevant. Those guidelines are basically guidelines provided that the case is set up and is been modified so that the bone itself and the gingival margins themselves are located where supposedly we are meant to be. And where that is, again, the bone is supposed to be located in a parabolic fashion, 1.8 to 2 millimeters, apical to cemental enamel junction in a scallop fashion, not a flat fashion, but a scallop fashion. And number two, the gingival margin is supposed to be located just at or slightly coronal to the cemental enamel junction. If we have a case where we have hyperplastic tissue and we have bone coronal to the cemental enamel junction, this must be modified. You can't just take out a tooth and stick in an implant because something is not right to begin with. Fix it, make it right, and then the last thing you do are your prosthetics. Put in a dental implant. Remember, the dental implant, all that surgery, all the therapy, it's a prosthetic discipline with a surgical component. So if we look at these slides, and we look at the diagrams, and yes, what do we have? Whether it's the tooth or the implant on the lower right diagram, it's showing you that we have biological width. We have 3 millimeters from the crest of bone on the facial to the gingival margin, and we have 4 millimeters from the crest of bone to the tip of the papilla. But in this particular instance, the bone is located 1.8 to 2 millimeters apical to cemental enamel junction. Now, what happens if we have a case that presents like this? Think golden proportion. We know that if we use the lateral as a base of 1, that the central incisor is 1.6 times larger than the lateral incisor, and that the mesial aspect of the cuspid is usually 6/10 the width of the lateral incisor. We know that if we have a width for a male of the central incisor that's 9 millimeters, the height should be 11 to 12 millimeters. If we take a probe and we see that we only have 5 to 6 millimeters of clinical crown showing, that means that we have half the anatomic crown being covered. Okay? If we want to do dental implant therapy, again, which is a prosthetic discipline with a surgical component, part of the surgical component is setting up the case properly so the prosthetics can be done properly. That means diagnosing altered passive eruption, diagnosing hyperplastic tissue, and going ahead and modifying it prior to doing either tooth-borne restorations or placing a dental implant. You don't know where to place the dental implant. Remember Yogi Berra, if you don't know where to go, and chances are you're not going to get there. If you don't set it up properly, how do you know at what level to place your dental implant? You won't. So if we have a case like we showed in the last diagram, and we look at the crest of bone, which is abbreviated COB, it is 2 to 3 millimeters coronal to the cemental enamel junction. Tissue will always be located 3 millimeters coronal to the crest of bone. So our free gingival margin is now halfway up the tooth. If we were to take out the lateral, how would I know where to go ahead and place my dental implant? Well, normally we're supposed to place the dental implant 2 millimeters below the adjacent cemental enamel junctions. If I don't modify this scenario with the bone and the tissue, number one, I can't get it there, and number two, you'd have a 5 or 6 millimeter pocket starting out, and you'd have very short teeth. That's not how you win and get a nice prosthetic result. When we talk about the principles of aesthetic integration, what we're talking about is being able to diagnose the case. Look at the gingival smile line. Look at the lip line. Look at the crest of bones. Radiographically, I can see where the crest of bone is. It's supposed to be 1.8 to 2 millimeters apical to cemental enamel junction in a parabolic fashion. The gingival margin should be located at or just coronal to the cemental enamel junction. If I look at a case like this, and I will show you a case shortly that was referred to our office, an implant was placed, but this case had passive eruption. The crest of bone is 3 millimeters coronal to the cemental enamel junction, which means that the free gingival margin is halfway up the tooth. How do you get a tooth, when you go ahead and restore this, to look like a tooth and act like a tooth if it's going to be half the size of the tooth it's supposed to be? So if we look at this tooth and we would go ahead and actually do crown lengthening, look at the mess we'd be in. If I took the crest of bone, which was basically where the location of the free gingival margin is, and moved it apically so that now it is 1.8 to 2 millimeters apical to the cemental enamel junction in a parabolic fashion, then what would happen is I'd now expose 3 to 4 millimeters of threads. And that's not a good way to win friends and influence people either, especially when this thing is integrated. Okay? The right way to do this is to diagnose the case prior to ever doing restorative, prior to placement of dental implants, correct the hyperplastic tissue, the passive eruption, if the bone is where it's supposed to be, okay, and then you have hyperplastic tissue, then do an aesthetic gingivectomy because we're not manipulating the bone. If the bone is at or coronal to the cemental enamel junction, you have to reflect the tissue. You have to move the new gingival margin to be located at or just coronal to the cemental enamel junction. You have to move the bone 2 millimeters apical to the cemental enamel junction in a parabolic fashion. Then you know you can place your dental implant. Then the rule of 3 and 4, 3 millimeters from the crest of bone to the gingival margin on the facial and 4 millimeters in approximately from the crest of bone to the tip of the papilla are relevant. But those two things that have been used ubiquitously are not ubiquitous. This is not a panacea. Those two numbers are only relevant if the case is set up properly or it's been modified so that we have a proper gingival smile line with the proper amount of biologic width so that in a full smile, the inferior border of the maxillary lip is congruent with the peaks of the parabolic curvatures of the gingival margins of the centrals and the cuspids. So again, these numbers, the 4 and 3, are relevant provided the case is set up. That's how you get aesthetic integration. If we take a look at this clinical case, this case was sent to me and they said, oh, can you go ahead and unveil? Can you do aesthetic crown lengthening on this case? Well, that diagram should give you a hint. What happened here? Half the tooth was basically covered with tissue. The bone was coronal to the cemental enamel junction, but yet the implant was placed. If I go ahead and crown lengthen this case, as you can see what would happen, I'd probably expose 3 or 4 millimeters of threads. So what do I have to do? I sent it back and said, I'm sorry, but I can't help you. This case, unfortunately, is a tragedy because this particular patient should have had crown lengthening done. And if you look at where the new gingival margin should be, okay, and we look at the horizontal line, and that new gingival margin is now going to be located at the cemental enamel junction, that dental implant and that grayness, that flatness is where the platform is because they didn't want to bury the platform. They kept it a little bit above the bone, which is okay, but not when you have passive eruption. So if I go ahead and were to scallop that tissue, not only would I show the whole platform, but I'd show several threads. And that is a travesty for this patient. So that is the take-home message. If we have passive eruption, meaning that the bone is coronal to or at the cemental enamel junction, and therefore by using the golden proportion and the width to length ratio, we can diagnose this hyperplastic tissue. In other words, diagnose short clinical crowns so that we can then go ahead and unveil the entire anatomic crown. Then we will know where to place our dental implants so we can have aesthetic integration. The critical factor is not abutment selection. It's having a properly placed dental implant and having the right quality and quantity of soft tissue over the prosthetic interface. Remember, prosthetic discipline with a surgical component. So at the end of the day, the person wants a tooth. And he doesn't want a tooth where one tooth is 5 millimeters tall and the other tooth is 12 millimeters tall. That person wants to have a beautiful smile with a nice gingival smile line where everything is set up the way it's supposed to be. Okay? If we look at a case like this where we had a blown out tooth and bone grafting had to be done, sometimes you have to go ahead and grow the bone, and once the bone heals, come back and do crown lengthening. Okay? Then you can place your dental implant. Remember, smile design, everything has to occur and be set up properly. But this can all be diagnosed and done at the treatment planning phase so that when the implant's placed, the crown lengthening can be done, and knowing that you may still have to do additional modifications. But in this particular instance, we've set up our gingival aesthetic line, which is a line that touches, it's an imaginary line, about 45-degree angle, with a line that's congruent with the facial midline, and it touches the parabolic peaks of the centrals and the cuspids. We had to do some more aesthetic crown lengthening. And what we end up with is a nice gingival smile line. This is at the time of prosthetic placement. This is at a 5-year follow-up. And if you notice, there is no bone loss, and we have our tissue filling in properly. We have stippled tissue, a nice gingival aesthetic line, a nice smile line. And we still have one more tooth that we're still hoping to get this gentleman to finish the prosthetic veneer on. Thank you for listening.